All right, let's get it started. Um, Good evening, everyone, and welcome. Thank you again for taking the time today to join us for tonight's webinar with Dr. Matthew Taylor. As many of you know, Dr. Taylor is a precision medicine physician at Raden Wellness, and he combines conventional medicine with advanced functional medicine to help patients uncover and address the underlying causes of complex chronic health conditions. His areas of expertise, which I'll name a few, but there's so much more, include long COVID, chronic infections, autoimmune disease, hormone optimization, cardiometabolic health, and personalized precision medicine. As many of you know, Dr. Taylor's approach is very unique. He focuses on not just what's happening, but why. And during tonight's presentation, please feel free to submit your questions in the comments or in the chat, and I'll keep my eye on it and we'll get to it at the end of the presentation. But literally, Dr. Taylor is such a wealth of knowledge. So thank you so much. And the floor is now yours.
All right, thanks so much. Thanks so much, everybody. I'm going to share my screen here and we'll get started on this. Two, I wanted to thank everybody for the flexibility. I know this was a rescheduled webinar, and quite frankly, the reason we rescheduled was because I injured my back and didn't finish this on time. So I appreciated the extra few days. So let's see. Let me share this. And how's this looking on your side?
It's perfect.
Perfect. Okay, great. All right. Well, we're talking about long COVID, root cause and its mediators. So basically, let's start with just setting some expectations to start with. So many attendees who are on this webinar may have a common story that they've been dismissed or know someone who's been dismissed or not believed when they're coming with this constellation of symptoms. Um, it could encompass a lot of things: fatigue, anxiety, a host of things which we'll go through. And the most important first intervention is credibility, and that's the credibility of the patient. So it starts by saying, like, your symptoms are real. I believe you, and I also want to be precise. When we take an integrative forward approach to long COVID, it can be quite rigorous. So we make hypotheses, we determine what kind of classification of the condition people fall into. We do safety screens to know that we're covering for things that can be easily ruled out. And much of the treatment and approach to long COVID is based on therapeutic trials. There is some guesswork involved, and I'll highlight where that guesswork falls into place when we don't have as robust an evidence base for what we do. The most important thing to recognize in sort of this COVID spike protein era is knowing the influence of spike effect or not is critical in all complex chronic and fatiguing illness. Immune derangement with long COVID is universal. This allows chronic inflammation and possibly infections, endocrine derangement, tolerance to medications, and more. So when we target this, we're going to be targeting this for safety, meaning avoiding things like clotting and organ damage. We're going to be focusing on immune imbalance, the spike protein in particular, and then the comorbidities that tend to go with long COVID. So with that sort of in mind, our map for this talk is going to be starting with what COVID is, what drives it, some of the different dysfunctions involved, and the testing and treatments, and then getting a little bit personal with some of the stories. Importantly, this is education. This is not a protocol. We are not giving personalized medical advice here. I'm likely going to move quickly through some of the mechanisms, even though that's my nerd candy and that's what I love spending time on. And I'll slow down on the what can we do sections. I also want to make something really clear up front, and that's that vaccine-related spike injury will be addressed explicitly, but carefully. It's not the same thing as acute vaccine side effects, and it is not the explanation for everyone with long COVID. So importantly, this is not an anti-vaccine presentation. This is an anti-dismissal discussion. Vaccines have reduced severe acute outcomes at the population level, and we should have love for anything that keeps people from dying. Yet there are rare and under-recognized persistent post-vaccination syndromes that are legitimate and legitimate to study and discuss. So we will address that stuff today. Over in the side, though the text is small, this is just a diagram of about 1 million COVID-19 cases and their symptomatic journey. Each of the colors represents a certain organ system and the symptoms involved, where you see many of these cases ended in hospitalization or the patient's death. What we're going to be focusing on is toward the bottom of this, the 16 to 20 weeks after initial infection and diagnosis. So with that, we will begin. So what is long COVID? Best way to describe this is it's multi-system weirdness. It is not a failure of willpower. Long COVID definitionally is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous relapsing and remitting or progressive disease that affects one or more organ systems. So that's the definition, 3 or more months, symptoms affecting one or more organ systems. Now, long COVID has many symptoms that you see are common amongst a lot of other conditions. It overlaps with a lot of named conditions also, like myalgic encephalitis or chronic fatigue syndrome, POTS, MCAS or mast cell activation syndrome, fibromyalgia-like pain. And many patients have been to multiple specialists trying to figure out what's going on. And importantly, the diagnosis starts with the person's story. The diagnosis is clinical. We should be thinking less about the labels associated with the person's history and collection of symptoms and more trying to understand that person's specific biology and the root cause of what's going on with them. Diagnosis of long COVID is clinical. It does not require lab confirmation of prior infection if the clinical picture is persuasive. So that's really important to know up front. We want to answer the question, what shared upstream processes explain all of these downstream clusters? So you see here in the diagram that all of these different conditions have sort of these overlapping features, and long COVID can account for any of these. So the big idea that I want to get across with this presentation is with root causes, it's sort of asking the question, what lit the match that started this whole process in the first place? And then mediators, which is what keeps the fire going. Literally the title of the presentation is root causes and mediators. So super important to recognize that at the root of long COVID is the SARS-CoV-2 infection, or this could be vaccine-induced spike expression in susceptible people. Not everybody who has vaccination gets this. There could be reactivated infections, and there could be pre-existing inflammatory terrain. The things that keep the process going are where a lot of hangups occur. So this is where things like mast cell activation, which we're going to talk about in a little bit of detail, damage to the endothelial lining of blood vessels and the circulation of the body, autoimmune disease. Dysautonomia is sort of a fancy word for the parts of your brain that you're not conscious of that control your heart rate, breathing rate, all that stuff. They sort of go awry. Mitochondrial impairment is the impact on the parts of our cells that produce energy. And then we have things like gut permeability, what has been sort of colloquially called leaky gut syndrome, which is a term I don't like that much, but in any case, we'll address that too. You might be looking at the slide and saying, but I had COVID like 2, 3, 5 years ago, how could it still be causing this? And the answer is that the original trigger may have altered regulatory systems, your immune system, mast cell thresholds, which we'll talk more about. A lot of things may have been altered, including coagulation, hormone feedback. And so we want to frame this as root causes and mediators because uh, the original problem that set someone off may not be there anymore. And what the person's dealing with now is sort of the post-infectious syndrome. So distinguishing that is going to be super important for everyone who's investigating this for themselves. This is a way of kind of looking at the big idea when I present this to patients, when I see them in a visit. And this is, I admit, a complicated diagram at first, and I will walk you through this, and this will not be the last time you see this diagram. This comes from a program called Cogence Immunology, which is a training program for clinicians teaching immunology concepts from a medical standpoint. And I think one of the things that is important to note here, if we want to label the big red V as the virus, we know that it infects lungs and GI tissue through ACE2 receptors. That's the way it gets into cells. And once it does that, there's a cascade of effects that happens. And each one of these nodes that we will periodically come back to and highlight is potentially either a point at which we can test or treat the person if it makes sense for their particular story. So while all this kind of seems like gobbledygook right now, I promise that near the end we're going to make sense of this and kind of address these things as we go. So let's talk about spike protein. This is the matchstick. This is the thing that sets everything off. It binds these ACE2 rich tissues and other cell surfaces. It signals innate immunity, the complement system, which is involved in clotting, cytokines, which are chemical signals that tell different immune cells what to do, mast cells, which we're going to learn a lot more about. They're sort of like the overly dramatic alarm system of the body. And then spike protein amplifies everything involved, inflammation in your blood vessels, clotting, nerve sensitization. So importantly, spike protein isn't poison in the cartoon sense. It's biologically active. It can bind receptors, interact with vascular biology. What I want to emphasize here is dose, duration, biodistribution. In other words, how widespread does spike protein travel in the body? Host susceptibility is important. So not everyone has the same effect from exposure to spike protein. And then context, because in every person who is exposed, they have sort of a terrain that a virus is entering into. They may have other medical conditions that are playing a role. But spike is the key that the virus uses to interact with cell surfaces, and that's what starts the process. So important nuance here is that spike is not the only mediator of long COVID. You can have viral RNA particles, proteins. You can have immune memory type of phenomena where certain types of T cells, an immune cell that goes after infections, they can be expressing a memory response to long COVID and be overactive. You can also get reactivated viruses alongside COVID, like Epstein-Barr virus, cytomegalovirus. This is very, very commonly referenced in the medical literature that COVID is often not the only virus at play. It's also true that microclots in blood vessels, mast cells, which are these, again, overly dramatic immune cells, and changes in mitochondrial function can all contribute and mediate the problem. I can make references available later if people want to reach out, but most of this stuff is coming from 2023, 2025 studies, and and basically just reinforcing the notion that coronavirus and spike protein activates all of these other things. So how do we distinguish whether the spike protein was due to an infection or due to a vaccination? Both involve spike biology, but they aren't identical exposures. So with the different proteins that are involved in a COVID virion, you have a nucleocapsid antibody, which is sort of you can see there in the middle of the diagram. Um, that antibody, if positive in a person's bloodstream, suggests that there was an infection exposure. Spike protein antibody can follow infection or vaccination, and it has to be interpreted with timing and history and certain assay limitations for the instrument that we use to check it. But baseline spike antibody and nucleocapsid antibodies are blood tests that we run to help us differentiate infection versus vaccine trigger. That's as we'll find out later, it's probably not the best method. It has some limitations to it, but we'll talk through that stuff a little bit later on. One thing I want to avoid and want us to avoid in our thinking around these antibodies is that vaccine spike protein isn't always persistent after someone's been exposed to it. That's a really important point. And also, high antibodies do not prove spike toxicity. So hopefully those are a couple of myths that we can bust at the onset of this presentation. But yeah, just really importantly, just because you have been exposed to spike protein doesn't mean it's always going to be there. And high antibodies on a blood test don't prove that what we're detecting is toxic. Okay, let's see. And I just made those points, so let's move on. Okay, so when talking about vaccine injury in a respectful, evidence-based way, a small subset of people do report persistent symptoms that begin after vaccination. Now, the best scientific stance for this is neither dismissal nor is it being overly certain. We have to document timing, consider the infection history, screen for dangerous adverse events, treat the physiologic pattern that we see in front of us, and it can be different for each person. Now, importantly, the references for this are the CDC vaccine safety for what it's worth. There's also a study by Yonker in 2023 in Science Translational Medicine that demonstrates the circulating spike protein causing myocarditis, which is inflammation of the muscle of the heart. There's another study in 2023 looking at duration and persistence of spike protein. Yet another one by Teodorescu et al. In 2023 looks at new and exacerbated POTS or postural orthostatic tachycardia syndrome after vaccination. We also have Bhattacharjee et al. In 2025, just last year. That's part of the Yale Listen study looking at post-vaccine immune signatures as a way to kind of track what's going on with people. That is preprint, by the way, just to full disclosure there. But I just say these to make the point that I'm not making stuff up here. We are talking about legitimate studies looking at post-vaccine injury. This is not something we should just dismiss. So, but the established stuff I mentioned, we are seeing some other case series where chronic fatigue syndrome comes as a result. And then the stuff that's under study right now, it involves these immune signatures and kind of special ways of assessing long COVID. Among the things that you see in that table on the right side of your screen, I would say that the subset of patients that I see most in clinical practice is about the fifth one down, where we're looking at vaccine-associated enhanced disease, where the type of immune pattern that we're seeing is something called a T helper 2 phenotype or skewed immunity. And I'll explain what that means. But essentially, T helper 2 cells are a type of immune cell that's very very active in hollow spaces of the body. Wherever you have a hollow space, whether it be the sinuses, the lungs, the gut, the bladder, genitourinary tract, uh, anywhere where there's an epithelial or endothelial lining, T helper 2 cells are sort of the main actors. And when those cells get overactivated, that produces a lot of symptoms that look an awful lot like long COVID and some associated conditions. So that's what I see the most, though I've seen maybe a handful of some of the other things on this slide. So again, coming back to whether we're looking at virus or vaccine-associated enhanced disease and why the symptoms are present, sometimes the immune system is acting like it's seeing the virus, even if it's not really there. And so both infection and vaccination engage these overlapping pathways, which we're going to go over, but they differ in magnitude, in their distribution throughout the body, the duration of their effects. Vaccination involves widespread distribution throughout the body. It involves uptake of certain cellular materials, depending on what type of vaccine a person received. And there's a persistence of this modified template for the spike protein or something that's spike-like that drives the synthesis in the body of an unnatural spike protein. And the immune system reacts to that in certain people. So in some patients, this fire may be a persistent ember. In others, the ember may be gone, but the smoke alarm is hypersensitive. And maybe a good way to visualize that, let's see if I can get this to work for us. Virus exposure. Then what comes next is we have the immune system that's too activated in certain places, whether it be these T helper 2 cells, which I've alluded to, or T helper 17 cells at the top. These are the drivers of autoimmune conditions, and these are the drivers of tissue destruction, presenting tissue to the immune system to be destroyed, thinking it's foreign material, but sometimes it isn't. And then we can also sometimes measure in the blood some of these overactivation type of molecules, for example, transforming growth factor beta, which is circled towards the bottom of this diagram. And that can give us some clues about what's going on from an immune standpoint. In other cases, it's underactivation of the immune system, where we have cells like T helper 1s or natural killer cells, things that are supposed to go out and fight infections for us that are exhausted. And there's reasons why that happens, including, but not limited to, other infections that could be present, other conditions the person may have, the depletion of certain antioxidant nutrients represented by GSH, which stands for glutathione. If you haven't heard of glutathione, this is sort of our master antioxidant. It's what kind of the liver uses for general detoxification, and that can be depleted and lead to these situations. And then the end result is we get, high histamine, migraines, edema, pain, POTS, brain fog, all of the inflammation in our central nervous system. And this is where a lot of people are wanting to understand what's the root cause, what's going on, and how do they get unstuck. So here, I'm going to back up for just a second. Right in the middle of this diagram, you see mast cells in the purple box. That's what we're going to address next, and you'll see why everything seems to converge on that spot. So let me get back to that. Okay. So think of mast cells like the alarm system that just doesn't turn off. It's excessive release of these granules, these little chemical beads, so to speak, inside the mast cell that get triggered. The mast cell breaks open, releases all of these chemical beads, and where they sit near blood vessels or near nerves or near mucosal surfaces, this one cell can be responsible for flushing, hives, diarrhea, reflux, palpitations, sleep disturbances, a whole host of things, even brain fog and panic-like surges. The references here are mostly from Afrin and Weinstock. These are the names of two physicians who are sort of the go-to experts on mast cell activation syndrome. So their names for reference. What's one important thing here is that diagnostic criteria for mast cell activation syndrome often include episodes of multi-system symptoms. They often include uh, objective elevations of certain things in the blood or urine, though that's very hard to capture. Labs are very difficult to prove positive in mast cell syndromes. And many patients actually have completely normal labs outside of the flares that they experience. So why is COVID part of the story? Because essentially, if we think of mast cells as the listeners for immune danger and that they react at certain thresholds, releasing all of their chemical mediators, think of COVID and spike protein as something that lowers that threshold or unmasks the susceptibility of some people for these conditions. So after a spike exposure, this would mean like the same food that you've always eaten, the same fragrance, heat, stress, exertion, exercise, even shifts in one's menstrual cycle, they can all provoke a larger response than before because the threshold for these cells has come down. Um, there are a number of papers that discuss this. Wu et al. In 2024 in Frontiers described SARS-CoV-2 triggering mast cell activation, neuroinflammation, and injury to the blood-brain barrier directly. And then just last year in the Journal of Virology, they showed mechanistic evidence of how coronavirus spike protein can activate mast cells through this really nerdy chemical pathway that I'll spare you the name. Um, so we've talked about mast cell syndromes. It can affect multiple different organs of the body, and sometimes this pattern of symptoms can be even more useful than labs. I listed the labs that a lot of practitioners may order, but importantly, the usefulness of these labs isn't always 100%. Essentially, the limitations are you have to catch someone in the middle of a flare, drawing their blood or having them urinate right when the flare is occurring. So that's tough to capture. The assays or the chemical tests to certain things like prostaglandins and leukotrienes and methylhistamine, they're actually difficult tests to do correctly. So that can be a problem. And so I think, long story short, normal tests don't exclude mast cell mediated symptoms. And again, references to Afrin, Weinstock, Sumantri is another one. And what often is the case instead is that we will approach mast cell activation syndrome through uh, treatments being the best test. So if someone responds to a treatment that is meant to treat mast cell activation syndrome, and they feel better from it, that's usually the test that tells us that we're on the right track. So let's transition for a second into the endothelium or the lining of the blood vessels and how this relates. Connecting endothelial dysfunction to symptoms without overdiagnosing the problem. Microcirculation issues can explain this why like a totally normal oxygen level or a totally normal echocardiogram or a scan of the heart doesn't always capture the intolerance to exercise or exertion that people experience. Um, so looking a little bit deeper, um, we can assess oxygenation. We can also assess certain inflammatory markers. We can assess certain types of proteins involved in the coagulation cascade and vitals. These all kind of help paint a picture, but But uh, this is something that is super important to just to note. Micro are um, are the subject of a lot of important research in long COVID. We shouldn't turn every single patient who we suspect of long COVID into some kind of clotting protocol. That doesn't make a lot of sense all the time. So we do need to always discuss with each individual risk, contraindications. There are treatments that are lower risk that can help with reducing clot burden. There are more aggressive treatments that have been studied where we might see really intense anticoagulation type of medicines being used in people. But that always has to be balanced with bleeding risk, with anemia, ulcers, um, surgeries around the same time, other medications maybe that might interact. So essentially, the main points I wanted to communicate here are standard tests for coagulation can be normal. There is specialty testing that's evolving. A lot of it's not universally available. Some is inferential. And then as far as treatment goes, circulation support, it has to balance the benefit with the bleeding risk. So I think that's fairly clear. When it comes to POTS and dysautonomia, this is when the autonomic nervous system can't reliably regulate itself. So this is where people will experience palpitations, shakiness, lightheadedness, heat intolerance. And the best assessment here is really just their vitals, their symptoms. Sometimes asking someone to bring in a heart rate and blood pressure diary is super helpful. If they use wearable devices, that too can be really helpful. And then often I'll refer to a neurologist to do a specialized type of testing called tilt table and QSART scoring, where this is measuring a couple of different things, including sweat output, and this can kind of really, cinch the diagnosis. The main rule with POTS and dysautonomia is uh, you know, don't exacerbate the problem. Don't overwork the body, but first stabilize it. And there's quite a number of things that are used in conventional and integrative medicine circles for this. People will often be on medicines that affect heart rate and blood pressure, things like ivabradine, midodrine. These may be things that people are familiar with. Pyridostigmine is another one that some people are on. Big considerations with these drug regimens is are they actually solving the problem? Because again, dysautonomia POTS is one piece of the puzzle. It's not the only thing. So if we're treating it in isolation, we may be missing part of what's really going on. And in many cases, I've been able to serve patients in coming off of their medicines for POTS because once we determined the cause, they didn't need them anymore. So now the plural of anecdote is not evidence, obviously, but I put that out there just to put the thought out that um, we're not always dealing with just one thing in isolation. All right, and then the mitochondria. So the energy regulation problem in COVID is pretty well established. We're thinking more and more that this is one of the principal issues that's going on with long COVID. And the goal with helping this piece of the puzzle is really pacing of activity, stabilizing the autonomic nervous system, really good nutrition, sleep, uh, some kinds of mitochondrial support, whether that's specified nutrients or specified types of exercise. Um, these are all sort of like, the non-sexy lifestyle medicine type of stuff, but it really does serve as the main foundation. We emphasize, uh, before crashes happen, stress hormones and adrenaline may be masking the energy deficit that people have. Sometimes symptoms can worsen hours to days later after someone's, exercised or exerted themselves. And it may not make immediate sense why their symptoms are happening when they can't relate it to a very recent trigger. Most important thing about mitochondria in this whole story is that there are no reliable direct mitochondrial tests that exist. Uh, there are companies that claim to test mitochondria directly, and it will just say that these have not borne out by reproducibility. Other independent researchers have not been able to prove that these assays work. So just want to point that out there that if you see tests that are marketed for testing mitochondrial function directly, it's probably not worth your time or money. The treatments tend to be personal, and they aim to address dysfunction across the entirety of the complex that spans the membrane of this small part of the cell. So there are 5 different parts to the cellular machinery that make the energy that we need to live, and all 5 of those parts have nutrients that affect them, drugs, peptide-based treatments that affect them, and so we really have to personalize it to what works for that person. It'd be remiss if I didn't at least mention the vagus nerve, the anti-inflammatory brake on the entire system. We think about the main neurotransmitter or neurohormone involved, acetylcholine, which can be helpful for cognition, which can help with gut motility, heart rate variability, calming down the immune system. And it's based on research into this acetylcholine system that novel treatments like nicotine, of all things, have been used in some long COVID patients and provided some relief. Now, this is not the same thing as restoring choline or vagal tone or fixing sleep or providing mitochondrial support. It is a band-aid. So that's important to note. But outside of nicotine, there are other medicines that sort of act on this acetylcholine system. And again, this needs to be individualized to the person. I also want to mention reactivated infections, thinking of this as like the old tabs reopening. Dormant infections can become noisy again when someone's exposed to spike protein or to a COVID infection proper. Most of these are in the herpes virus family, since these are viruses that once someone has been exposed to them, they tend not to be something you cure. They sort of hide out in neural ganglia in the nervous system. They lie latent, and a lot of people won't even know that they ever have the virus because it tends not to reactivate in most people. But for some, it does, and so that can be a disruption to the person's entire symptoms. Uh, it's true also that beyond viruses, mycoplasma, certain bacteria, certain funguses that may be underrepresented in the gut, or perhaps things like C. diff, which is a bacteria that tends to cause a very violent diarrheal type of illness that puts people in the hospital. These types of things can become opportunists in a immune system terrain that's kind of damaged or impaired. And that's where, doing some investigation into where some of these different microbes might be hiding can become important. Vector-borne illness can fit into this picture, but this really has to be carefully looked at about whether the history fits what's going on there. It's a particular pet peeve of mine, which I'm fully okay, putting out there, that I reject the notion that vector-borne illnesses like Borrelia, Babesia, Bartonella are chronic diseases. These are eradicable infections. But there are untreated versions of these infections. There are types of these infections that hide out in the body using biofilms. So I mention it, but it's often the rarer case that these are part of the picture. I think it's also important, just real quick, to mention that we don't test everything in everyone. We look for clues, things like swollen lymph nodes, sore throat, night sweats, fevers, air hunger, unusual rashes, um, exposure history. So again, coming back to the basics of the very first biomarker or clue we should be looking at is the person's story. And if you listen long enough, often the patient's going to tell you the answer. Important to mention hormones. Hormones are sort of can become the collateral damage when COVID occurs. Thyroid can be disrupted. We usually see this as low free T4, fatigue, cold intolerance. We often see this in people whose prescription for thyroid replacement is changing abruptly all over the place. We may also see this in shifts in the curve of cortisol as measured through saliva measurements. This is sort of the best way of assessing adrenal function and determining if we're in a low or high adrenal state. Sex hormones, whether that's through cycle flares or sensitivity to certain things in perimenopause, impacts on sleep and mood. These are all important things to note. And then if we're looking at insulin resistance or shifts in lipids and other metabolic problems, these are all things that we can't ignore. Um, it's super important to note that when someone has long COVID or mast cell syndromes, they can have a primary endocrine or hormone problem. They may also have a transient endocrine problem or a short lasting one where it's happening because of the illness. It's not that they have a new diagnosis of an endocrine disorder. So a lot of times support for these hormone type of situations doesn't mean that we chronically replace the hormones. It may mean that we just stabilize a person through a particular hard point in their treatment process. Maybe we temporarily put them on a steroid or things like stimulants or sex hormones, but these often are just temporary to get people through a bad part of the treatment program and don't become permanent replacements. One thing that's important to note at this point is we can categorize people who have long COVID based on this tool called the clock scale, clock being the one of the authors that from which this diagram comes from. This is basically a way for us to quickly understand what is the degree of disability that somebody is experiencing as a result of their illness. And we can give them a grading score, as you can see there on the screen. Depending on which grade, that can inform how aggressive we are with therapies. It can inform things like, do they need additional support? Do we need to reach out to ancillary services like social work or occupational physical therapy? So it's just a way for us to kind of get a sense of how much more support does a person need. So people who I'm treating for long COVID, we may discuss this. And this slide is translating this idea of a direct trigger with like a whole case assessment of the person's entire comorbidities or all of the conditions that they might have at the same time as long COVID. So a direct trigger might be low energy or fatigue. And what we look for in the history in that case would be, when do they have their crashes? What time of day? Uh, where does that crash happen with respect to their physical activity? What's their sleep like? Do they have anemia or nutrient deficiencies? And kind of going down the list, we might look at MCAS, mast cell activation syndrome, for instance. We're looking in a story like that for a very particular symptom pattern, triggers, mediator labs, if it's possible to get them in a flare. Uh, People who have vascular or clotting problems, we're looking for coagulation context using labs, or we're looking for certain red flags on a physical exam. And it could go down as far as, gut or barrier dysfunction issues where the lining of the intestines is compromised. And we might see stuff in their story like bloating, histamine, food intolerances, or they might be coming to us with past stool testing that they're asking us to interpret. So the main important thing here is which systems are driving symptoms, and that typo was on purpose in case you caught it. So. All right. When we're looking at spike protein and assessing a person's immune system, importantly, the question isn't generally do they have antibodies or not, but what is the pattern or the terrain of this person's immune system? How are they presenting? So we can do spike antibody testing, and like I said earlier, this can differentiate between post-vaccine and long COVID, PVLC for short. And this can trend usefully potentially, or in the case of a previous infection, it can wane. These antibodies can kind of die, wane away despite the previous infection. There are non-antibody tests that exist, and for reasons that I could only speculate and be entirely frustrated about, they aren't available in the US. But there are direct spike protein and spike modified RNA tests that are available. And InModia is a company you can look up if you're curious about that. One ancillary test that I will use sometimes is something called a T cell ELISpot. Now, brief biology lesson, antibodies are made by B cells, which arise from the bone marrow, and they're one part of a person's immune system. Another part are T cells, labeled T because they come from the thymus gland, which sits about here in your chest. And an important thing about T cells is that for every infection a person's ever exposed to, they have one type of T cell that responds to that specific infection. So that's cool because we can test the T cells specific to long COVID and determine if this is an active infection or if it's more of a latent or memory response to SARS-CoV-2. And that's often coupled with other types of these ELISpot tests to determine if we're looking at T cells that are exhausted, if they've become senescent, in other words, they've lost their ability to repair themselves. And that can lend all sorts of context to understanding how this person's immune system is either dealing with or not dealing with a COVID or spike protein exposure. I'll also do things like KIR or killer immunoglobulin-like receptor genotyping, mouthful. This is looking at genetic testing of a person's natural killer cells. Since these are often the first line of defense against infections, the picture there is a natural killer cell Pac-Manning a COVID virus. I thought that picture was beautiful. So that's something that we can actually assess. We can know if a person's natural killer cells are programmed to respond to infections in a very aggressive way, or if they're kind of lazy and it takes a really high threshold to make them do what they're supposed to do. And then there are a lot of other immune-based testing that we can do through companies like LabCorp or iLab and the like. So we can generally get a really good picture of what's going on with a person's immune system broadly. And this informs personalized treatments. When we look at autonomic, or the part of our nervous system that controls heart rate and some of the other mast cell related symptoms or reduced cognition or disturbance with sleep, all of those things, how we assess those is pretty individualized. Like I mentioned earlier with autonomics, oftentimes I'm referring to a neurologist who can do specialized testing to confirm the diagnosis. This is often important when we're determining, does this person actually need a whole drug regimen to control their symptoms or not? With activation syndrome, again, being a little repetitive here, but labs are less useful unless there's a flare. We kind of base it based on symptoms. And then for things like brain and central nervous system health, we can do cognitive screens. One of my favorites being something called CNS vital signs. I'll often refer people for sleep studies. complete with EEG to measure their circadian rhythms and different brain waves. And we also look for neuropathy clues or whether MRI findings are revealing. Uh, let's see. Oh yeah, I included a couple of these things just so that people can see what the QSART, CAS scoring, these types of things, looking for dysautonomia may involve, where people are checking um, heart rate variability, blood pressure responses to certain maneuvers, things like that. And then the CNS vital signs, you can see there that there's a number of things that this computer-based test measures, including a person's verbal and visual memory, their response time, their executive function, and the like. So this can often serve as a really good baseline for where people are starting. And then after we treat them, we can remeasure these things and see, what kind of impact we made. So before I dig into treatments here, just want to mention that treatment sequencing is a key concept when we're addressing long COVID. We do have to stabilize a person first, and then we start targeting things. So uh, this really, again, coming back to the the less sexy stuff, making sure that a person's sleep is optimized, their nutrition's optimized, that they're eating like real foods, they're getting plenty of fluids, and they're pacing their activity. They're not overdoing exercise or activity. Once we get that under better control, then we start moving into do they have a mast cell type of story? Do they have more pain type of syndromes? And it's important we stay agnostic to the types of treatments that we're using and we use what works. In many cases, we're using medications. Now, I know that some people come into this with sort of a naturalistic bias where they'd prefer to use medications as a last resort. And there are certain situations when it just makes sense to use a medication to stabilize somebody at the onset. So we talk through these things individually, per case. And it just means that, when we're being integrative forward, that doesn't mean like more therapies all at once, but we just have to, be careful in how we sequence things. We'll then treat drivers, we'll treat spike protein directly, we'll treat clotting disorders, gut barrier dysfunction. This is where kind of, we have to look for the specific problem that the person's presenting with. And this can include looking for signs of what's called central sensitization or mind-body syndrome or complex PTSD. They all kind of fall under the same bucket. Not opposed to looking at how a person's spiritual health is affecting the overall picture. And the point ultimately is that we work on rebuilding a person's mitochondrial function, the microbiome, or balance of bacteria in their body, especially the gut, if it's out of whack. That's the medical term. Uh, and then just rebuilding resilience in the person. And then finally, we measure things over time, whether it's a person's physical function, symptoms, labs. This is an ongoing process. So the foundation of everything is we want to reduce crashes and raise the floor. These are not basic, they're necessary. So in every patient who has long COVID, we have to address pacing of their energy, looking at things like stop before you crash, looking at protecting your mornings, especially the next day after you've exerted yourself, and really looking at slow and progressive load in things like strength training or just general activity. We have to look at things like sleep and circadian, light timing. This can go as detailed as ensuring that the light exposure that you have at 6 p.m. or later is only floor mounted or wall mounted light sources and not overhead light. This can actually be a factor in some people. Nutrition, super important that people get adequate protein, that they adopt a more, plant predominant type of diet, um, and aren't overly restrictive with food intolerances or not just assuming that restricting more foods is the answer. And then we look at things like vagal tone, breath work, really just trying to develop a sense of safety in the person. And one modality that's very popular is limbic retraining. It's an umbrella term for a way of doing brain exercises that rewire the brain to reduce neuroinflammation, particularly in the parts of the brain that control things like pain, anxiety, depressive symptoms, and the like. And ISTDP is a sort of in-person version of this. It stands for Intensive Short-Term Dynamic Psychotherapy. And this is something that I offer to patients when the case calls for it. When we're looking at mast cell activation, the main goal is we calm the alarm, we reduce the triggers that the person's being exposed to, and then we block the mediators. And this often takes the form of different antihistamines. This might take the form of other types of strategies trying to lower some of the chemical mediators that are released in response to mast cells. Um, there are medicines that specifically do this. I'll mention one because it's worth a mention. Montelukast is one type of medicine that's known as a leukotriene inhibitor. It really does fit the picture here very well, but importantly has a black box warning for neuropsychiatric symptoms. So, just because a medicine is very direct in treating the aberration in a person's physiology doesn't mean it's still the right medicine for some people. So, worth a mention. Uh, some individuals will use aspirin or other prostaglandin lowering types of medicines. I think that's really important to do only with clinician oversight, since the risk of GI bleeding and that these types of things can exacerbate mast cell type of situations. Another one I'll mention, just because it starred here, is ketotifen. This is a antihistamine and mast cell stabilizer that does need to be compounded into an oral form, but is often useful for a lot of people. Rupatadine is another very effective mast cell stabilizer that unfortunately is not available in the US. And since this is, a non-CME and, lay public focused talk, I'll just say that it is very common for patients to seek outside of the US sources of some of these medicines. Cromolyn is sort of the classic old school mast cell stabilizer, and then a drug that's more and more garnering attention for a variety of things. A drug called Pentosan, which is an extremely potent mast cell stabilizer and is very useful in this condition, but carries with it some, we'll say, annoyances. It has to be intramuscularly injected, and I realize that's not fun. Other things like luteolin and quercetin, which come from different plant sources, that too can be, natural high potency. And then finally, we look at rebuilding a person's tolerance. So again, mast cell treatment approach: reduce triggers, block mediators, stabilize mast cells, and then rebuild tolerance. I'm highlighting those again because I just want to walk you through how I would present this to a patient with this map again. So again, here we're looking at um, identifying the mediators, whether that's the Th2 cells, whether that's overactivity of something called CGRP, a certain calcium channel that can be overactive in migraines, or things like TSLP, interleukin 33, interleukin 25, that are released from gut and lung tissue. This is where we might employ things like perilla, which is an herb that you find it's used often in Asian grocery stores, in Korean cooking, and we can use concentrated extracts of that to specifically inhibit interleukin 4, which is the trigger that Th2 cells release to tell mast cells to go ahead and become more active. There are also things like TSLP inhibitors. Um, Most of these types of things that inhibit TSLP or interleukins are what we call biologics. They're often used in rheumatoid arthritis and other rheumatic conditions. And so we may not be gravitating towards those, but there are natural products and peptide-based treatments that can work on the exact same mechanism, for instance. And then mast cell stabilizers might be used to treat right at the cell type that's the principal problem, and whether that takes the form of drugs or other natural products. And then finally, building resilience may involve restoring the balance of these T helper 1 cells or natural killer cells that we want to fight infections for us, or to balance the high T helper 2 cell activation that's going on. So once I walk through this with a patient and it's making sense, then we start to identify, well, where are the treatments that work on each of these nodes for that individual? So for building resistance, that might take the form of bicalin, which comes from the Chinese skullcap mushroom of all things, or we might really lean into limbic retraining and trauma-informed therapies. We might really get specific about physical exercise, or use thymosin-based peptides to kind of, re-stimulate the parts of the immune system that are impaired. So just using this as an example to kind of paint the picture. In autonomics, first we got to improve circulation and stability, then we choose medication for what we see in front of us. So it's always going to start with making sure fluid status is intact, that we're using compression wear, that a person's appropriately conditioned. Then we might lean into heart rate control or blood pressure support. Importantly, with some of the blood pressure support medicines, I started them. Again, these sometimes are needed temporarily, but they're also medicines that in more cases than I've prescribed them, I've worked on de-prescribing them, because we found that if we sort of solve some of the other issues, or help a person calm down in their nervous system, a lot of the other treatments are more tolerable, and de-prescribing some of these things becomes a lot easier. Brain treatment can get a little bit outside the box, we'll say. So here we're looking at things where the primary first step is, how do we lower inflammation? Whether that's using mast cell type of medications, nutrition, working on sleep repair, usually with things that are medications, things like trazodone or Remeron, to help a person reset their circadian rhythms and sort of repair their sleep cycle. Low dose naltrexone has also been used. And then we may look at things that work on executive function, careful use of stimulants, extra careful when we're using a drug called modafinil, which has unfortunately kind of taken a front row seat in these sort of biohacker communities as being a sort of regarded as a smart drug, or something that's you know, sort of a magic bullet for certain cognitive function issues. The problem being that because modafinil requires a certain enzyme for it to work called COMT, certain people who have a mutation in that enzyme may be taking a medicine that doesn't work for them at all, and not only doesn't give benefits, but may actually be harming them, increasing dopamine in their neurons to a point that it can become toxic. So giving modafinil willy-nilly, not a great idea. This is one of those cases where I do try to get somebody's genotype first. And then guanfacine, or Intuniv is the brand name. This is a drug that was marketed for ADHD as a sort of non-stimulant. And there's some interesting research coming out about this drug being stabilizing for the microglia, or the immune cells of the brain and the spinal column. And that can be useful in a lot of cases. We then might look at supporting the choline system. This is where I mentioned earlier using low doses of nicotine or other forms of choline to replace what's missing. And then finally, we might look at repairing mitochondria or oxygen delivery with certain types of therapies like blood ozonation, or just looking at how do we approach psychological safety. Often improves when a lot of underlying things are addressed, though. So if we're treating mast cell, if we're treating POTS, if we're treating post-exercise malaise, if we're fixing a person's sleep, a lot of this stuff kind of fixes itself. So again, we may not address the stuff directly. We don't do this in every person. Looking at spike protein, this the treatment approaches here usually start with things aimed at binding or blocking entry of the virus into cells. There are a lot of things that fit this category from a natural product standpoint, though potency is probably not stellar. But this would include things like quercetin, curcumin from the turmeric spice, dandelion leaf, milk thistle. There's a lot of things that have been studied for this purpose, at least based on their mechanism of action. One interesting one that I'll mention is digoxin, of all things. Now, for those who are unfamiliar with this, this is a heart failure medicine that at first garnered a lot of interest because it does three interesting things. It can serve as an inhibitor to prevent SARS-CoV spike protein from binding those ACE2 receptors and entering human cells in the first place. It seems to suppress the sort of inflammatory storms that can happen when COVID spike protein gets out of control in the body. And interestingly enough, it seems to be able to reduce blood clots. So lowering prothrombotic factors, all of these were theoretical benefits of the drug. And despite all of these interesting findings, the real world clinical data wasn't as promising. There was a pretty big study, US military health system, studied like 14,000 people, about 400 or so people were given digoxin. What they found is that they didn't have any better protection from SARS-CoV-2 compared to other people who were on other forms of standard care for heart failure. So interesting. It may work on a mechanistic level, but population data doesn't seem to jive with it. So I mention it because it is you'll see it sometimes used in sort of cutting edge or forward thinking types of practices. Looking at degrading the spike protein itself, that sometimes can be done with certain natural products like natto and leberkinase, proteolytic enzymes, and weirdly enough, a drug called cyproheptadine, which is a really old antihistamine. Some emerging evidence that maybe it does this. Circulation support, looking at hydration, antiplatelet and anticoagulation therapy. You may even see in literature people doing what's called triple therapy. This gives me the heebie-jeebies. This is putting somebody on dual antiplatelet therapy with aspirin and clopidogrel, putting them on a factor 10 inhibitor called apixaban and a proton pump inhibitor all at the same time. Believe it or not, people are on these regimens. They kind of scare me. But monitoring bleeding risk, looking at medication interactions, maybe measuring very particular labs like alpha-2 antiplasmin or SAA protein. These can be things that can give us inference the state of this kind of issue. And then we may look at antiviral type of medicines or reactivations, whether it's the herpes virus family, looking for clues like sore throat, lymph node swelling, neuropathy, or pain that's not in the muscles. And then particularly with CMV or cytomegalovirus, sometimes these people worsen when they're taking phospholipid-based supplements. We think that's because giving a person phospholipids, the virus basically uses those right up to build more of its own cell membranes. So interesting concept, hasn't been totally fleshed out, but interesting. Persistence of the virus can also be a factor here. Off-label medicines, whether it's things like Paxlovid, certain antivirals combined with other things. We've seen some weird combinations like Maraviroc, which is an antiviral with a statin. I had one patient who was on this regimen that turned into a really interesting case I might share sometime. Uh, so there are some sort of experimental realm stuff that's being tried in this area. If we want to push more of on an integrative front, we usually are going back to the basics, looking at fixing the gut, fixing a person's sleep, making sure they're getting enough protein, making sure they're stable from an immune standpoint. Um, we may explore things like targeting the glycocalyx, which is that really fragile inner layer of blood vessels to ensure it's healthy. There have been researchers looking at stellate ganglion blocks, which is basically putting an anesthetic into a bundle of nerves at the base of the neck in order to prevent signals like danger signals in the nervous system from reaching the brain. So there's all sorts of, interesting things that can be tried here. Most important thing in all of this is you want to look at what's the evidence for lack of harm of all of these things first. If they're low risk and might help, and these are often things that are worth a try. Lastly, we may look at mitochondria, depuration, bioelimination. People have to avoid the toxins in the first place. They have to move, they have to hydrate, they have to be able to have bowel movements. There are therapies looking at light exposure, whether that's near infrared or far infrared or red light therapy. Occasionally, chelation therapy is explored. This is a pretty controversial subject, though, especially when it comes to testing and treatment. My general stance on chelation is that in extreme situations, it may be necessary, but importantly, chelation is never benign. Using a chelating agent to mobilize heavy metals in a person's body will always cause some kind of inflammatory response or some type of harm. So it has to be done very carefully and in people that we've sort of brought to a point of more health. I wouldn't do this in a sick person. Um, Peptide type treatments are aimed at mitochondrial repair, improving a person's metabolism. These are based on the extrapolation of their mechanism. There aren't trials that show that these are directly helpful in long COVID, but because of the way that they work, there's enough of a low risk mechanistic assumption that they may help. And then thymosin alpha 1 is, is a peptide that improves the competence of antiviral medicines. It may be useful in certain reactivation situations and situations where there is detected immune exhaustion. We use specific blood tests to measure that. And then I'll mention EBOO, which stands for extracorporeal blood ozonation and oxygenation. This is a therapy that is aimed at improving microcirculation. It's aimed at kind of preconditioning the body to handle more oxidative stress. There aren't a lot of high-powered studies on this yet, but again, this is sort of based on the idea that if we can help a person set the terrain so that future therapies will work more efficiently, that's sort of the rationale behind this. And this is something that, if the case may call for it, I'll delve into this with patients in a little bit more detail. So that was a lot. I think the closing message I want to leave you with is that um, you are not broken. You're just stuck if you're someone who's dealing with this condition. It's not a condition that improves with any magic bullet. This is something where we do have to understand the biology of the person enough to make the next right step. Symptoms are real. You should fire any doc who says that these symptoms are all in your head. We do need to identify what the dominant pattern is. And then, as with everyone, we stabilize first, we treat the mediators, then we rebuild capacity, and then reassess over time. This isn't a short process. But if this is something that you're looking for help with, happy to help you every step of the way. COVID science is moving really quickly. We're learning things all the time. We're not always going to have treatments that help an individual. Sometimes we may get lucky and find a really interesting off-the-wall thing that really helps that particular person. So responses are varied. This is definitely personalized therapy. And the point is to focus on function and quality of life, not just labs. Uh, so with that, if this is something that you're looking to get help with, I typically encourage patients to bring a symptom timeline, maybe a log of their crashes, medication supplement list, and maybe like their top 3 item goals that they're hoping to accomplish when they work with us. So if you think I can be helpful, happy to. And with that, I'll say thank you and turn it back over to my team.
Yeah, we got a lot of questions. Do you have a few minutes just to answer a few?
Sure, I'll pull up the chat here and see what I can
It's
see
been
what I can
it's
figure
been
out.
quite it was a great conversation. I feel like a lot of people, have a lot of questions. And I will say the recording will be sent to everyone, but um yeah, if you want to scroll through, I can read them out to you.
Oh, sure. Yeah, I'm happy to just answer these real quick. So I'm starting at the top of the chat screen for what it's worth. Somebody mentions that they came down with COVID last November. Throat felt like broken glass with swallowing, a lot of fatigue, malaise. Took Paxlovid as prescribed. Symptoms disappeared shortly after. Yeah, not unusual. Paxlovid, the mechanism, it's preventing further entry of the virus into cells. So you're essentially lowering the viral burden. So I'm not surprised that that worked, at least at first. The person goes on to say that they had burning tongue syndrome, which appeared after their COVID booster. It was starting to become more mild as they came down with COVID. Okay, so what you're describing is what I mentioned earlier in the presentation, where someone's exposed to a vaccine, perhaps a booster shot, and then they get exposed to the virus later on. And this can produce that skewing of the immune system toward a T helper 2 dominant pattern where a lot of the hollow spaces of the body, including the oral cavity, can become more inflamed. That may explain some of the burning tongue syndrome. Um, this person mentions that the internist seems to indicate this can be long COVID. Yeah, I mean, this fits the pattern of what's going on with that. So this would certainly be a situation where I'd want to assess this person's uh, immune function in a variety of ways, understand how they work, um, prove to them that they're in this T helper 2 dominant state, and then design treatments that are personalized to what we find. The next person mentions that symptoms like dysautonomia, POTS, chronic fatigue syndrome have been around before COVID. How can you tell from a clinical perspective that COVID's at the root and not something else? Yeah, beautiful question. Thanks for that. It's true. Like this is what I mentioned very in the presentation. A lot of the same systems that are affected by these named diagnoses overlap with what's going on with long COVID. So we have to remember the metaphor again. COVID's sort of lighting the fire, and then all of these conditions are what happens when the fire keeps burning. When you've sensitized a person's neuroendocrine immune system to a point where maybe COVID isn't at the root anymore, but something else is. It's very possible. How we tell from a clinical perspective, this is where lab testing can be really helpful. This is where those T cell based tests to determine is there a active versus latent response or memory response to COVID specifically can be helpful. So this is something that we can answer is the ultimately point. Uh, let's see. Someone mentions resurgence of pre-existing conditions can occur. The person had POTS as a child. It went away. It came back 1,000-fold after COVID. Yeah, and someone says that happened to them too. Yeah, totally makes sense. Here we're looking at these are likely people who have a susceptibility to what we call hypersensitization of the autonomic nervous system. And it doesn't take very much for that system to become overwhelmed. Uh, most of this is, let's see, forgive how this is going to sound. I don't mean to kind of apply something like a stigma here, but the same mechanism that underlies complex PTSD, where hypersensitization happens in the part of the spinal column and brain that governs these POTS type symptoms. Um, it runs along the exact same system through the periaqueductal gray in the spinal column up to the amygdala and anterior cingulate cortex in the brain, respectively. These are the fear emotional processing centers and the pain centers of the brain, and these interact very strongly with the autonomic nervous system. All of the things that we're not conscious of that our nervous system controls that we would go crazy if we were conscious of them. That's what the autonomic nervous system works on, and that can easily become resensitized with a viral exposure like this. Let's see. Next one. Well, let's see. Having a little trouble with the mouse here. Okay. Let's see. Pre-syncope, post meals, even after fresh foods that are lowest in histamines. Yep. Let's see. Diet. Oh, okay. So what this person is describing is a diet that's extremely limited to a select number of foods. Um, this is nuts. I agree. Um, yeah, so my general approach is we have to understand why the food intolerances are there. That's the question we got to answer. What we often discover, now not in every case, but honestly, most of the patients I serve, it is not the foods. Like uh, the foods themselves are not the root of the problem. What tends to be the case is that if there's disruption of the microbiome of the gut, the different bacteria that live in you and produce lots of really healthy fatty acids from the fiber you eat and make nutrients for you and neurohormones that make you feel good. If they're disrupted, can be a problem. Also, the actual lining of the intestines can be inflamed or permeable, like literally stuff passing through the lining of the gut that shouldn't. That triggers an immune response. It's not that you're allergic to the foods, it's that the barrier function is compromised, and so you're just reacting to everything. So the idea here is that we want to fix the underlying issue in the gut. We can learn that through specialized stool testing, what the specific problem is. And then once we solve the root problem, a lot of my patients have been able to start expanding their diet and eating more things. Um, so I realize that for this person asking the question, that might sound like totally wild, but that's been my experience working with people. So for long COVID brain fog, do you have any concrete suggestions for treatment? So obviously I can't I can't give direct medical advice to this question, but I'll say in general, when we were looking at that slide on, in fact, let me go back to it. There was a specific slide on brain treatment that I addressed. Again, when we're looking at brain fog, we have to understand where is that coming from. Is this an inflammation-driven process? Is this the microglia, the immune cells of the brain and the spinal column are hypersensitized or impaired somehow? Is this more of, I don't know about this, the question asker, but is this more of a neurodivergent kind of situation where we should be looking more into sensory deload and some of those types of in-person therapies? This may be a situation where different forms of choline can be helpful. The root issue, though, is we have to understand where in that person's story can we get clues about when this started, what its cadence was, if there's any patterns that emerge. So again, it's not a one size fits all thing, but there are very specific treatments that we can employ that I've listed some of them here. It does depend on what the underlying story is. Somebody asked if microclots are at play in our symptom picture. I think I addressed that fairly well in the presentation. Somebody mentioned nicotine worked for them. That's awesome. And yeah, it sort of depends what form. Most of the time, when we're using nicotine or trying it, we'll start with like half doses of the lowest dose gum, for instance, to see if they tolerate that first. Um, Usually I won't advance to patches because that's equivalent to like a pack or more a day. Um, so that seems, excessive in most cases. Somebody asked me to explain psychospiritual a bit more. This really just involves kind of digging into the story of to what extent do um, spiritual experiences, whatever that means for the individual, factor into stress events, major traumatic or life events. Could they potentially be the trigger that pushed people into sort of a body problem coming from a spiritual trigger? This can often take the form of trauma-informed therapies, whether that's things like accelerated resolution, is something I'm a big fan of. Um, Things that work on the assigning purpose to movement types of therapies, where doing things like Tai Chi type of exercises or EMDR, which is the eye movement desensitization reprocessing. These are therapies that work because they assign purpose in the therapy or the movement you're doing to the movement that crosses the midline of the body. And there's a particular part of the brain that is being stimulated in that case. It sort of is like a big full circle here where the spiritual components of a person's story triggering a physical problem, then in turn being related to a neurological problem. So I think bottom line is when I treat people in a holistic way, I'm looking at all three. What are your thoughts on lysine and monolaurin for antiviral? You know, I'll admit in my experience, I haven't seen them work that well. These have been been around a long time. They're purported to work based on mechanism of action. Uh, I guess I'm skeptical that they're the best choices. Is what I can say on that front. Um, Somebody's asking about recording, which I'm presuming will be provided. And someone's asking where I'm located. So I mainly conduct telemedicine in Illinois, Michigan, New Hampshire, New York, and Florida at this time, expanding licenses as needed. And yeah, obviously working in person at the Radon Wellness Clinic at the Lincoln Park location. And you can reach out to the clinic to learn what my in-person schedule is if that's of value to you. Let's see. And a lot of thanks and heart emojis. Thank you for that. And thanks for the compliment. The person who mentioned precise. You know, full disclosure here. I'm part of an effort to make precision medicine a recognized board specialty in the United States. So that's an ongoing effort. That's probably a few years away, but yeah, it's definitely a top word in my lexicon. Let's see. What are helpful supplements for endothelial health in general? I love the way you phrased that question so that I wouldn't be making it a direct medical advice. Um, so endothelial focused supplements, there's a handful of them out there that have made the claim that they are helpful for endothelial function. And some of them actually have low-powered studies behind them. This is where you look at products like Arterisol, Vasconox, Endocalyx Pro, things that are aimed at addressing the integrity of the inner lining of blood vessels. They may or may not work. Um, I've seen them be helpful in some patient cases and not in others. Um, Honestly, this is probably not the most satisfying answer, but the number one quote unquote supplement for endothelial health is cardiorespiratory exercise. And I'd say, second to that, lifting weights. I know that's not the most satisfying answer, but it works. Don't be afraid of lifting weights no matter what your age or no matter what your experience. Let's see. Let's see. Someone asked if COVID lives in lungs and brainstem. Is that something I subscribe to? Yeah, it's a tough question to answer because I'm afraid I wouldn't be able to answer it precisely. So, hmm. So it is true that viral particles, spike protein, things of that nature after a person's been exposed can can still be in the body, usually in endothelial lining. But yeah, I guess I'm struggling with the question a little bit. You know, I wish I had a better answer for that, but I'm not quite sure how to answer it. Sorry. I think that was everything. So again, yeah, if you found this helpful and you're looking for more support for you or a family member dealing with this stuff, certainly reach out to me. And yeah, uh, we'll likely do more of these webinars. I think the next time we hold probably be another Ask Me Anything style where you can submit questions ahead of time. And yeah, happy to see you next time.
Thank you, Dr. Taylor. And I will send everyone also more information on how to book with Dr. Taylor as well in a recap email. So look out for that probably tomorrow morning. But thank you all so much and enjoy the rest of your night. Thank you.
Thanks so much.
Bye, Dr. Taylor.